Long case mitral stenosis. Mrs. A. Begum, 35 years old, married housewife, non diabetic, normotensive, non smoker, hailing from Bishwanath, Sylhet, was admitted into this hospital on 10th August 2022 at 11 am through outpatient department with the complaints of increased shortness of breath for 20 days and palpitation for 20 days. According to the statement of the patient, she was reasonably well 3 years back. Then she noticed shortness of breath during heavy exertion, like carrying pot of water from pond, washing clothes, doing household works hurriedly, and it was relieved by taking rest for a while. Now, her shortness of breath has got worse for last 20 days, which occurs during mild exertion, such as doing daily activities like walking in home, bathing and dressing. Now it needs prolonged rest for improving her shortness of breath. She has repeated history of sudden awakening at midnight due to breathlessness and needs to go to window for open air, and it improves after 10 to 15 minutes. She has no history of difficulty in breathing during lying flat. Her shortness of breath is not associated with cold, dust, fumes, taking drugs or food, or any exposure to allergens. There is no diurnal or seasonal variations. She has also complained of palpitation for last 20 days, which she feels irregular in nature. She has also mentioned with the onset of this palpitation, her shortness of breath has got deteriorated. She had similar type of recurrent palpitations for last 6 months, which persisted for few minutes to few hours and improved with taking rest. But for last 20 days, this palpitations has not improved and persisting in nature. This palpitation is not associated with taking tea or coffee, anxiety, depression, chest pain, dizziness, lightheadedness, loss of consciousness, increased frequency of micturition, vertigo or vomiting, weight loss or loose motion. She has also mentioned about coughing out of blood in 3 episodes within last 3 months, and the last episode was occurred 20 days back. The amount of blood was about half cup, mostly red in color mixed with some mucus. Her such condition got improved spontaneously after taking prolonged rest. She has also history of occasional cough with throaty sputum production with increased shortness of breath, which was improved with taking rest and some drugs. She gives no history of transient loss of consciousness, swelling of legs, abdomen or neck swelling, chest pain, fever, skin rash, joint swelling, joint pain, weight loss, increased appetite or hand tremor. She denies any complaint regarding hoarseness of voice, difficulty in swallowing, focal weakness of any side of the body, or any unexplained fever. On query, she gives history of several episodes of sore throat, fever with joint pain and swelling during her childhood, about 12 years of age, which was suggestive for rheumatic fever, and was treated by a local physician, but she denies any prophylactic treatment. She has no history of known ischemic heart disease or hypertensive heart disease or any known congenital heart disease, diabetes mellitus, asthma, COPD, childhood recurrent respiratory tract infection, tuberculosis or contact with TB patient, and documented COVID-19 infection. Her bowel and bladder habit is normal. With these complaints, she had consulted with several physicians, and after evaluation, they have said that she has some sort of valvular heart disease, but she could not mention the name of her disease. She is taking some drugs for last 1 year irregularly, but could not mention the name of the drugs. She had never admitted in any hospital for her illness, and she had never undergone any invasive procedures. She is married for 15 years and has 3 children. Age of her last child is 5 years. Birth history of all of her children was uneventful, and all were delivered by normal vaginal delivery in local Upazila hospital. Her menstrual cycle is regular with normal cycle and normal in amount. She is immunized as per EPI schedule and got all doses of COVID-19 vaccination also. She is non-smoker, non-alcoholic, not betel nut chewer. She lives with her husband, has 3 children, she has 2 siblings, and her parents are alive and none of them have any same type of illness. She has come from low socio-economic condition. Her husband is a farmer and only earning member of her family. On general examination, patient is looking ill, body build average, cooperative, decubitus on choice. Pulse is 110 beat per minute, irregular in nature, variable in volume, no radioradial or radiofemoral delay. Condition of the vessel wall is normal. Pulse deficit is 12. All peripheral pulses are present. Blood pressure is 100/70 mm mercury in both arms. There is no postural drop. JBP is raised 6 cm from sternal angle and there is absence of A wave. Respiratory rate is 18 breaths per minute and normal in character. Temperature is normal. Patient is non-anemic, non-icteric, non-cyanosed, non-dehydrated. Leg edema and sacral edema is absent. There is no clubbing, leukonychia or koilonychia. There is no thyromegaly or lymph adenopathy. Hair and skin condition is normal. There is an IV cannula in situ in left forearm. On precordial examination, as far as I expose my patient, apical impulse is visible in apical area and seems to be medial to the left mid-clavicular line. It seems to be there is no chest wall deformity, size and shape of the chest is normal and there is no visible scar mark as far as I expose. There is presence of epigastric pulsation, but there are no visible suprasternal and supraclavicular pulsations. Apex beat is located in left fifth intercostal space, just medial to the left mid-clavicular line, 9 cm from midline. Size is normal and tapering in nature. There is presence of diastolic thrill over the apical area, best appreciated with the patient in left lateral position. Left parasternal heave and palpable P2 and epigastric pulsation is present. First heart sound is variable, mostly loud in nature. Pulmonary component of second heart sound is loud in pulmonary area. There is presence of opening snap with a low-pitched, localized, rough, rumbling, mid-diastolic murmur in the apical area. Grade 4/6 in intensity. Best heard with the patient in left lateral position with breath hold after expiration with bell of the stethoscope. There is absence of pre-systolic accentuation. There is also a pan-systolic murmur in the left lower sternal edge with grading of 3/6 with no radiation, which used to increase in intensity with breath hold after inspiration. There is no other added sound. Lung vases are normal. Other systemic examination reveals normal. This is all about the history and examination findings of my patient. So my provisional diagnosis is severe mitral stenosis due to chronic rheumatic heart disease with pulmonary hypertension with atrial fibrillation with NYHA class 3. Thank you.